I think a long way has passed since we have started looking at angle closure disease in a different perspective. And a lot of old terminology has now been phased out, and the terms like chronic as asymptomatic, subacute, intermittent, those kind of terminology had a lot of limitations and difficulty in applying to epidemiological studies. So therefore, didn't correlate to the degree of angle closure, does not give information on natural cause. All this has moved on to the newer and the recent classification of the spectrum of angle closure disease, which we now call as PACS, PAC, and PACG. I'm sure many of us are already aware of what this spectrum is all about. PACS is essentially asymptomatic angle closure, narrow angles. Primary angle closure is iridotrabecular contact, 180 degrees or so, with some sine K and pigment blotches and so on, but normal disc, normal field. PACG is full-blown glaucoma with all the features of angle closure. This is in brief. Who is at risk? The older age, female gender, hyperopes, shallow ACs, short axial length, thick lens, thick peripheral iris, family history, and particularly family history of first-degree relatives having angle closure disease and so on. So the primary mechanism of angle closure disease has been said to be at 4 levels. As, most of it actually occurs in a pupillary block mechanism, 75% or more, it is said. There's also a plateau iris component. There could be a thick lens, there could be a thick peripheral iris, and so on. But essentially, when you diagnose angle closure disease, most of us would actually start off with an iridotomy and then review and decide, is there any other mechanism in addition or over and above the primary angle closure and pupillary block. So the classic pupillary block, we all know the iris bombay and typical appearance and pupillary block mechanism, in which you do a YAG-PA and the pupillary block is relieved with the YAG iridotomy. Whereas the plateau iris is slightly different, in which you suspect a plateau iris configuration by the clinical suspicion of the sine wave sign, as you can see on gonioscopy. And this can be confirmed by the UBM test and other tests and so on. But the suspicion remains whenever you see these kind of signs, you suspect a plateau iris configuration. After you do a PI in a plateau iris configuration, it is called a plateau iris syndrome, in which the situation of a patent PI, the IOP actually increases on pupillary dilatation, despite the PI being patent. This has been described roughly about a third of the eyes after primary angle closure YAG PAs and so on. The plateau iris syndrome is generally managed by some of us, you would use once a day or twice a day pilocarpine eye drops in long term to keep the pupil myotic. And the others would probably think of laser peripheral iridoplasty, depending on the experience and your knowledge of the understanding of plateau iris syndrome and so on. But plateau iris syndrome patients cannot be dilated even after YAG-PA. And there have been new concepts and new diagnostics available in terms of relative lens vault and thick peripheral iris, and newer imaging technologies give us information on this. The last word has not been said, and we do have technology which is evolving. We do have normative, we don't have normative data, so we don't really know what is the normal lens vault, what is the abnormal, where to draw the line and say the lens is the culprit and so on. But these are all evolving technologies and issues, and we probably will hear more of this in the years to come. Look at the epidemiology of angle closure glaucoma itself. You will find that it is less common than POAG, but more blinding. That is why the importance of angle closure glaucoma comes in, that it is a more blinding disease. You look at, for example, the Chennai urban survey, you will find that 14% of angle closure disease was discovered to be blind, at least in one eye. Whereas open angle glaucoma, the blindness is much less. And the key facts about angle closure glaucoma, more importantly, is that about 85% of people detected with glaucoma were unaware of the disease. And 2/3 of PACG in these kind of large studies have been seen by an ophthalmologist earlier and were treated as open angle glaucoma because gonioscopy was not done or not done properly. And PACG may actually progress more rapidly than open angle glaucoma. So how about very often we fear that acute angle closure is common and we're scared about dilatation and so on. And the data which we have, especially among Indian chronic angle closure glaucomas, we do find that asymptomatic angle closure is far more common than the acute attack of angle closures. Whereas acute attack of angle closures are probably more common in Chinese population, northern China, than southern parts of other parts of the world and so on. Also more common in Chinese Singaporeans and among people in Finland and so on. So acute angle closure is not so much of a problem as asymptomatic silent chronic angle closure disease. So the natural closure of the natural course of the disease is that about 22% is said to progress to PAC and 29% of PAC is said to progress to angle closure glaucoma. So other structural damage can be noticed in the spectrum of angle closure disease when you have an acute attack, when you had chronic angle closure glaucoma. You can have endothelial cell loss, you can have iris damage, ischemic damage, you can have pupillary changes, glaucoma flecken, trabecular meshwork due to PAS formation, trabecular damage can be there. Of course, when the IOP is acutely elevated, you can have an ischemic pallor of the disc, but the slow chronic elevation of IOP in a chronic angle closure may usually result in the typical glaucomatous changes in the optic disc. This is a classic picture of chronic angle closure glaucoma, in which you see the PAs, you see the pupil, you see the atrophy in the sphincter, and you see the classic disc changes in the RNFL changes. And this is chronic typical primary angle closure glaucoma. In a PACA situation, that is asymptomatic narrow angles, you would treat selectively people who need frequent mydriasis and dilatation, you would treat. But PAC, you should treat all patients with primary angle closure. And they have raised intraocular pressure and signs of angle closure, you need to do a YAG-PA first. Of course, in primary angle closure glaucoma, you would start off with YAG-PA, followed by IOP management, either medical or surgical. But needless to say, all of the spectrum of angle closure disease needs monitoring and follow-up. It's not just enough to do a YAG-PA and then put them on medication and not see them thereafter. A follow-up is very, very important. Medical therapy, many patients after the YAG-PA and chronic angle closure would require, even after the patent PA, would require medical treatment to control the residual increase in the intraocular pressure. So topical medication like prostaglandins have been found to be effective even in angle closure therapy, angle closure glaucoma. Surgical options you would consider when the IOP is very high and you find that IOP remains uncontrolled, extensive PAs and some cataract also is noticed, then you can think of either a primary cataract surgery or a combined surgery of cataract with glaucoma and so on. But mind you, the surgery in angle closure glaucoma is not easy and it needs some experience. Postoperative shallow ACs, UVL effusions, malignant glaucoma, cataract formation, all these can occur. So role of the lens has been debated and people have identified certain factors which you can identify as a lens fault as the role for removing the lens in certain aspects of the spectrum of angle closure disease. There has been a role for just the Phaco or the cataract surgery alone in mild PACG, in which removing the lens alone will relieve much of the pupillary block, will also reduce intraocular pressure, and maybe better to follow up with a better quality field and maybe manage the IOP post-operatively with medication. So lens removal does have a role if in the presence of a cataract is the current scenario. So there is some publication about the role of clear lens extraction. This is clearly controversial. And what we would like to say is the EAGLE study was not perfect in the way it was done. So the take-home messages from my talk today is that primary angle closure glaucoma is a very important cause of blindness and many cases remain asymptomatic undetected. Gonioscopy is very, very important to diagnose PACG. Laser iridotomy is the first step in managing PACG. After that, IOP must be monitored. Clear lens removal remains a controversial topic. Fellow eye management is very, very important. One eye of angle closure disease or the spectrum, you must learn to manage the other eye. Consult patients about the disease for the regular follow-up and long-term follow-up. And definitely family members of people who have angle closure disease must undergo a screening. You do find siblings and relatives can have angle closure disease. So thank you all for your attention.